Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith-Rogers, producer of Public Health on Call. Last fall, we partnered with the Stoop Storytelling Series to present an evening of stories about the personal impacts of public health. We are releasing some of those recorded stories as a series, and today, in part one, we hear from two storytellers. Carolyn Suffren, an OBGYN and medical anthropologist, talks about working with pregnant people behind bars. Cicely Franklin, an overdose prevention specialist with the Baltimore City Health Department, talks about the difficulty of providing harm reduction services in her day job while having a family member with substance abuse issues at home. Let's listen. Dr. Carolyn Suffren is an OBGYN and medical anthropologist with a joint appointment at the Johns Hopkins School of Medicine and the School of Public Health. In 2004, I was a first-year OBGYN resident in Pittsburgh, Pennsylvania, and I was on call one night, as I was many nights in a row. And sometime in the middle of my shift, I get a phone call. Carolyn, come to room 4 for delivery. So I'm running down the hall, and when you're an intern in OB, you really have one goal, which is don't drop the baby. So this is what was going through my mind as I was running to room 4. So I open the door, I get into room 4, and the scene is kind of like any other hospital birthing room, any over-medicalized Western hospital birthing room. There were IV poles, there was an electronic fetal monitor, there were lots of doctors and nurses, and there was a pregnant person who was about to push out her baby. So everything about it was pretty standard looking, except for one thing. The mom-to-be was shackled to the bed. This is not something you train for. This is not something I could have even imagined. I was so nervous, and my thoughts about dropping the baby were they didn't dissipate, but they were deepened by my fears of what if something happened, what if there was an emergency, and we couldn't do what we needed to do to help this person and her baby. Well, these thoughts were racing through my mind, and somehow the baby was born. Well, not somehow, the mom was strong and amazing, and I caught the baby. I didn't drop the baby. I handed the baby. Oh no. Yes. I didn't drop the baby. Thank you. I didn't drop the baby. I'm just going to hold this because I probably will drop this if I try to put it in. And so I handed the baby to the mom, and she cradled it in her one unshackled arm. In this moment, I was so deeply troubled. I was so terrified. I was troubled, I was terrified, I was overwhelmed. Much less so, I'm sure, than the mother. But there were so many things running through my mind. I had never thought about the fact that there were women behind bars, let alone pregnant people. I had so many questions. What kind of prenatal care did she get? Did she get any? Why was she in jail at all? And why did she need to be shackled? Could she really escape in between her painful contractions with an epidural that numbed her legs? One thing I did know is that this was medically unsafe and deeply inhumane and unethical. And as these things raced through my mind, I had other very practical questions like, what was going to happen to the prescriptions that I wrote for her chart at her hospital discharge? Would the jail fulfill those? And what would happen to this baby? So fast forward a few years after that, I finished my residency, never dropped a baby, and I moved out to San Francisco to do a fellowship in family planning at UCSF. And I was encouraged to pursue my nascent interest in reproductive health care for incarcerated women. And so I reached out and pretty soon got connected to the medical director of the San Francisco County Jail. And I told him, I said, I'm really interested in access to contraception and understanding what's happening and implementing, expansion of contraception services for this population. And he said, okay, that sounds interesting and seems important. Why don't I give you a tour of the jail? So I said, sure, that sounds great. And so I got my clearance. He gave me a tour of the jail. I saw the housing units. He gave me a tour of the clinic. And at the end of the tour, he said, so, Carolyn, what do you think? You want to do some clinical care here? That's not what I was expecting him to say. And I knew that I should probably say yes, but I had no idea what I was getting myself into. I did say yes. And within a few months of being an OBGYN at the San Francisco County Jail, I became quite overwhelmed with the contradictions that I was immersed in and that I was complicit in. Things like I learned that incarcerated people have a constitutional right to health care, and they're the only people in our country with a constitutional right to health care, right? So they get most of their rights stripped of them, yet they gain this right that you and I in the so-called free world do not have guaranteed as a right. I learned from my patients that many of them, jail was the only place they accessed medical care, the only place they got prenatal care. The reasons for that were not immediately apparent and are many and complex and things that I explored over the next several years and continue to explore. But for many, this was their medical home, which is deeply troubling, right? I also learned that my stereotypes and expectations of the people who work behind bars were not necessarily consistently true. Now, I did see custody officers be abusive to people and fulfill my stereotypes of them abusing their power, but I also saw custody officers comforting women experiencing miscarriages. I saw people show tremendous compassion, and I also saw healthcare providers in the jail acting more like custody officers and disciplinarians than healthcare providers. So a typical day in the jail clinic was very confusing in a lot of ways because on the one hand, here I was trying to provide care in a space of punishment. That's the biggest contradiction. And yet I was in this clinical space where there was a waiting area, there was a nurse's station, there were 3 exam rooms, there was a microscope to look at microscopy for various samples, and there was even an x-ray machine. I would call out to the waiting area and say, Miss Smith, you're next. And I would look Miss Smith in the eye and say, hi, I'm Dr. Suffren. It's nice to meet you. How can I help you today? And Miss Smith was taken aback. This simple pleasantry was shocking to her, being who she was, an incarcerated person coming in and out of jail for most of her adult life. I also learned how medical power in jails is much different. It's similar in a lot of ways to the power and authority that our society gives physicians in the community, but it's different. Things like ice and a bottom bunk become medicalized. I had to write prescriptions for these very mundane things because they don't have any control over their living environment. And for a menopausal woman who's having a hot flash, she needs ice because that's about all she can do. And yet it became this highly sought after commodity. So over time, as I became entrenched in this environment, I sat within these contradictions. I took care of pregnant people. I took care of people throughout their reproductive lifespan. And I learned some of what happened to those babies. Stephanie gave birth while she was incarcerated at the jail. She gave birth at San Francisco General Hospital, the county hospital. When it was time for the baby to be discharged, her mom came to the hospital, picked up the baby, took the baby home, and Stephanie got out a few weeks later and was able to be with her baby, but not in those first several weeks. Kima, on the other hand, when she gave birth at the county hospital, she didn't have that kind of a plan. She didn't have that kind of a family member. Although she had designated her sister to take care of her newborn, turns out her sister had an open case with the Child Welfare Agency, and they wouldn't allow Kima's newborn to go with the sister. And so that baby went into foster care, which just broke her heart. And I can still hear the wailing in her voice when she learned that. So Kima went back to jail. She tried as hard as she could to provide breast milk for her baby, who was still in the hospital for a little bit longer while they were trying to find a place in the foster care system for that baby. And I remember taking these precious bags of breast milk in a tote bag full of ice, putting it in the basket of my bicycle and riding the 10 minutes from the San Francisco jail to San Francisco General Hospital for that baby to get even just an ounce of that breast milk that she poured her heart into making. So I left San Francisco in 2014, and my clinical practice now is no longer in a jail. Still do obstetrics, and I still haven't dropped a baby. But I still do, I have dedicated my career to improving reproductive health care for incarcerated people. So I conduct research to try to understand the scope of the problems, to document how many pregnant people there are behind bars and what happens to those pregnancies, to understand the complexities of their motherhood experiences and how our society devastates them and their families. I also am involved in advocacy efforts. I help write policies to try to standardize reproductive health care for incarcerated people at a national level, and I write policies around best practices. But I also know that really the best practices to improve reproductive health care for this population is for them not to be in jail or prison in the first place. My advocacy also involves working closely with currently and previously incarcerated women who are leading the charge in helping to pass state laws that prohibit the shackling of pregnant people. And in 2004, when I started this journey, there was a state, Illinois, that had a law prohibiting shackling of pregnant people and people giving birth. And now, as of July of this year, there are now 40 states, plus the District of Columbia, and the federal government that have laws prohibiting this practice. But I also know that this is not enough. It still happens even when there are laws. And so I think about that. I think about that night in Pittsburgh many years ago. I wonder what happened to that mom. I wonder if she's traumatized by this experience. I think about that baby who's now 18 years old. I wonder what their life is like and if they're even together. And I wonder what I can do. Where I did nothing in that delivery room, what can I do so that this can all be different? Thank you.
Okay, so our next storyteller is Cicely Franklin. She is a proud mother of 3, and she is 47 years old and born in the awesome month of June, according to her. She has worked in human services and public health for well over 20 years. And for the past 6 years, she served as a program assistant in the Baltimore City Health Department Community Risk Reduction Service. So she provides harm reduction services, HIV and hepatitis C testing, and treatment referrals. Come on up.
Hello. So, growing up, I grew up middle class in the Northwood area. Amazing experience as a child to come up. Late teenage years, high school time, got pregnant, had a baby. I started to notice a change in my aspect of living. I noticed that my mom, she was going through some mental health issues. She was actually a bus driver. So I'm like, okay, everything seems cool. I graduated from high school. However, we were losing our house. So the house was being foreclosed on. Kind of hard for me because I grew up in the house. I lived there since I was about 4 or 5. That was the community in which everything happened amazing in my life. So, okay, I was really disturbed by it because I was like, okay, I'm 18. Maybe I wish I could find a job. Maybe I could keep the house. I don't know. Didn't understand what was happening because that was just how I was brought up. During that time, my grandmother was sick. She was going through medical issues. So I overheard that my mother had an addiction problem. Something I was really not knowing. I knew my dad was an alcoholic. Culturally, it's like that's not a big thing. Everybody kind of accepts the alcoholic. It's kind of okay, but the addiction to drugs is kind of a little bit different, especially after the epidemics that we've had throughout the years. So it was hard for me, but then it kind of made me realize what was really happening. That was really why we were losing the house. She no longer worked for the bus anymore. All of these things were taking place. Me and my mother's relationship was like crazy, up and down, in and out, round and round, all of that wonderful, amazing things. So I actually always wanted to work in public health, human services. I liked it. Kind of wanted to save the world, thought it was amazing. However, everybody's like, no, it's no money in social work. No, do something else. And I'm like, I want to do this. But I tried everything that they said, and then I had that aha moment. It's like, oh, no, do what you want to do. You can do it. So fast forward to now, I become in this aspect of public health. Now, this was crazy because, of course, having a mother who struggles with addiction, having a father that's an alcoholic, all of these things I see. Crazy, crazy, crazy. Because all I think of, why can't you just get better? Why can't you just get it together? Everybody else goes through it and gets over it, but why can't you? So I go into this field, not fully knowing about the field, but learning about the field. Then I work in the program where we actually give syringes to people to help them keep using drugs. Okay, at the beginning, I was like, does this really make sense? Because here I go on this end, I'm like, yeah, I think that you should just get yourself together. But on this end, I'm like, okay. So then you learn and you're informed and then you're educated and then you're like, hey, maybe that is the right thing to do. Maybe that does work. Maybe you got to meet people where they are. Okay, I'm in it. I'm in it doing it. I'm going to learn everything I can and I'm going to do the best and I'm going to be the best person I can. However, there's the dual dynamic inside of me that says it's a different status with your mom. Okay, so I'm like, yeah, you don't qualify with them. You need to get it together. That's not your thing. But fast forward, COVID happens. COVID is crazy. Of course, we all know that. However, I still work all the time, every day I'm in the office. Sometimes I'm in the office later than others because I gotta get things done. Everybody else is closed. So I'm in the office this one particular evening. I get the frantic, crazy call from my daughter. She's screaming, she's crying. My daughter at the time is probably 28, she's 30 now. So I'm like, okay, what's going on? I can't talk to you if you're screaming. Grandma, grandma, grandma. I'm like, oh my gosh. So she's like, she not up, she not waking up, she's out. Like, God, Jesus, Lord. Now, it takes about 8 minutes to get from my office to my mom's house, but it took me about 4. Not gonna explain how that happened, but I got there in about 4 minutes. I took all the Narcan that I had in my car. As many times as I have performed trainings and tell people how to use it, how not to use it, what to do, what not to do, I actually went in, saw her laying out, moved her, called her name, did all of those things. But I honestly used 32 milligrams of Narcan on her. It was really hard for me because I didn't respond as the daughter. I responded as the health professional. I probably still haven't processed it because I think that when you have a family member in addiction, you're always not sure. And it's really a dual struggle because you have to be empathetic to the clients that you see. I see people in the van all the time. I see people in community events, and I have to explain to them, and I gotta meet them where they at, and I gotta smile, and I gotta be this person. I'll be like, hey, da-da-da-da-da. But when it comes to my mom, I'm really not that person. I'm like, what? That's just the suit of armor that I have because of that. But education and just patience definitely helps. So I'm thankful. We still up and down, but what it has done is build a greater me, a greater program assistant, a greater community engagement person, a greater daughter, a greater mother, a greater friend, because you never ever know when you could be in the same position that somebody else is that you're helping. Being in this field, it's not black and white. It's like orange, purple, green, white, orange. It's different. So it's like, it's not a streamline, but education is definitely key. You can't feel bad about feeling bad. You can't feel bad about things not being quite okay as you want it to be. So with that, I am just thankful that my mom's still here. I was able to know what I needed to know to help her, like I would do for anybody else. But I'm glad that I'm still able to work on a relationship because we still have time. Thank you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.